Good morning to those joining us on the Pacific time zone, and good afternoon to those who are joining us on the other parts of the United States. We welcome you to our webinar today focused on the 2019 Revised Adapted Clinical Guidelines, Medication Management for Patients Experiencing Homelessness Diagnosed with Diabetes. This webinar is being presented by the National Healthcare for the Homeless Council with support from the Health Resources and Services Administration. My name is Darlene Jenkins, and I am serving as the moderator for the presentation today. We will have with us Dr. Lawrence Chang, who will be our main presenter on this webinar. This is our agenda for this presentation. This will be a 60-minute webinar. It will last about 50 minutes, and then we will reserve time at the end of the presentation for questions and answers. So if you have questions, please put them in the chat box that is below the presentation. If you are having technical issues, please contact Cecilia at the Council's office, and that number is 615-226-2292, and she will be able to help with any assistance that you may be having, any trouble you may be having. Also, I'd like to remind everyone that this webinar is being recorded, and it will be posted on our website within 3 business days. So if you go to our website, nhchc.org, within 3 business days, you'll be able to access this presentation. Before we start with Larry giving his the overview of the medication management section of the adapted guidelines, I'd like to just give some announcements. We are giving this webinar in October because we recognize that next month is actually Diabetes Awareness Month. We're hoping that by having this webinar now, it will give participants and those of you who are listening on the webinar an opportunity to look at the recommendations, to perhaps focus on one area of improvement, and that you can implement that during the month of November. So we purposefully did this webinar a little early to give you a chance to look and to implement during the next month, Diabetes Awareness Month. Also, you will have access to the guidelines. We will put that into the chat box during the Q&A period so that you will be able to access them. There is a widget on that guidelines that asks just 3 quick questions about your organization and how you plan to use the guidelines, and then if you're willing to provide us feedback. Of course, when we put the guidelines together, this is really trying to give some recommendations, and those of you who are implementing, if you would be willing to give us feedback of how it's working, if there's any adjustments that are needed, we would really appreciate that. That helps us keep our work fresh and to really meet the needs of those who are using our materials. So again, if you're willing to give us feedback once you have looked at the guidelines and read them over and implemented, we would appreciate it. Also, as an announcement, we are having an upcoming Diabetes Learning Circle, and this is really trying to focus on some quality improvement around diabetes. The applications are now open, and they are due October 18th. The Learning Circle will be really 6 sessions. We will have one session introductory, and then sessions will focus on particular topics such as root cause analysis, shared visits, a food pantry and A1C, and then looking or hearing patient voices and individuals with lived experience also with the diagnosis of diabetes will be sharing some of their experiences. So we really welcome you to join our upcoming Learning Circle that will run from October 24th through December 5th, and we'll be missing that 1 week within Thanksgiving, but it will be a total of 6 sessions. So this is the purpose of the webinar. Again, we want to announce the release of the revised adapted guidelines, and we want to ensure that the audience will be able to identify at least one medication that will maybe used to manage type 2 diabetes. We'll also be providing, when Dr. Chang gives his presentation, he'll be providing some up-to-date information on medication management. I'm sure that you'll be very interested in some of the material that he will be presenting today. So I want to just highlight, before I turn it over to Larry, what we some of the changes or what we included in these new adapted guidelines. So we did our first edition of the guidelines in 2002, and then we did our first revision in 2007, and then our third edition was in 2013. And so this is actually our fourth edition of the adapted guidelines. We really have tried to, with the 2019 American Diabetes Association, their guidelines, trying to align them with those guidelines, but we also understand that there are some special nuances when treating individuals experiencing homelessness with the diagnosis of diabetes. And so we try to not only kind of go by the guidelines that have been set by the ADA, but also we put a spin for recommendations of at-risk and prediabetes as well as type 2 diabetes. We've included a session on the importance of screening for social determinants of health and adverse childhood experiences as they relate to a chronic disease such as type 2 diabetes. There's also an extensive section on nutrition, including some links to how to screen for food security. We've included the management of problems and complications. This includes looking at the dental and vision and foot care and cardiovascular disease, as well as hypertension and erectile dysfunction. All those are also included in the guidelines. And of course, we've included a section on comorbid conditions. This includes substance use disorders, nicotine dependency, mental health, and cognitive impairment, in addition to traumatic brain injury. So hopefully we have really tried to incorporate much of the information that is needed for the field. And again, if you find that the guidelines are missing something or you have some recommendations, we recommend your feedback. We have also in the guidelines the abridged recommendations, appendices, and resources for you to look at. One of the main sections in the guidelines is on medication management, because we understand that that is a very important part of diabetes management. And so we are very happy today to have with us Dr. Larry or Lawrence Chang from the Valley Homeless Healthcare Program. And he is going to present the section. He actually wrote this section for us in the guidelines, so he's very familiar with the information that he's going to give you. I'd like to tell you that Larry graduated from the University of the Pacific with his doctorate of pharmacy in 2016, and he completed his postgraduate year 1 residency program at the Santa Clara Valley Medical Center in 2017. He joined the Valley Homeless Healthcare Program straight out of residency, and he obtained his board certification in ambulatory care earlier this year. Larry is currently going on his 3rd year of work at the homeless healthcare, where he specializes in chronic disease state management. He specializes in chronic disease state management. This includes diabetes, congestive heart failure, hepatitis C, anticoagulation, chronic pain and opioid use disorder, and hypertension. Larry believes that pharmacists play an important role in the healthcare team, and he hopes to continue advocating for his profession's involvement in practice moving forward. So we'd like to welcome Larry today and really appreciate him sharing his knowledge with us. And at this time, I'm going to turn this over to him for his presentation.
Okay, thank you so much, everyone. Thank you, Darlene, for the introduction. It looks like these slides are currently uploading right now. So we thank you for your patience, as they should be uploaded any minute now. I'll go ahead and start once the slides are uploaded. Okay, wonderful. So it looks like the slides are up. Again, I just want to introduce myself. My name's Larry. I am a pharmacist, and I do work at the Valley Homeless Healthcare Program here in San Jose, California. I will be talking about medication management for patients experiencing homelessness with diabetes, but really you could take this and you could apply it to anyone, really, especially if you have patients with a history of non-adherence. This talk is kind of aimed towards patients who have a difficult time taking their medications and getting under control. I have nothing to disclose. So the objectives of this talk today, I'm going to be talking about the newer diabetes agents that have recently come out, but there's not too much usage as we had expected in practice. And so this is kind of to help you familiarize yourself with what options you have, because there's some pretty incredible stuff out there. The second objective is to, talk about what we can do as clinicians, both clinically and non-clinically, to help patients improve their adherence to their medications and even monitoring of their sugars, because that itself is like a whole other battle. In 2003, the World Health Organization released a statement that talked about how improving adherence alone can have greater impact than any other interventions out there. And so as clinicians, I think it's so important that we put our patients in a position to succeed. We need to put them on medications that they can adhere to. Otherwise, what good is it at all if they're not taking it to begin with? And so there's a lot of different ways that we can help patients to improve their adherence. Some non-clinical strategies. So these are things that, that I have found to help my patients significantly. It is so difficult for my patients who are homeless carrying around a ton of bottles. Many of them have difficulty reading. And so one thing I do is I put stickers on their bottle. And so I'll put a yellow sticker on a once daily medication that they should take in the morning, and I'll put a blue sticker on the bottle that needs to be taken at night, and that way they have a really nice visual cue to help them to know when to take their medicines. I also help them to fill a pill box. Often it's so hard to take meds out of the bottle directly, every single dose. And so having a way to organize it is really nice. Our clinic is able to actually use purchase pill boxes using a fund that we have, and we kind of help patients, teach them how to fill their own pill box. Sometimes we fill it for them. But I find that the pill boxes are really nice to help them get a little more organized, because they already have so much stuff carrying around with them, and medication bottles are often really overwhelming. The last thing that we have is we have blister packs. I don't know if you guys are able to work with pharmacies that have the ability to blister pack meds, but something that I often do for the patients that can't do the pill boxes is I blister pack all of their meds for the month, and so it's all pre-packed, comes with their ACE inhibitors, their blood pressure meds, psych meds, everything that they might need can be blister packed all together for the entire month. So that's another option to look into. As for clinical strategies to improve adherence, we as providers have a lot of power in choosing medications, and we really need to roll with resistance. And that's something that, I need to get patients to buy into taking their medicines. And so when I find that they're non-adherent, we as providers need to listen to them, listen to why they're not taking their meds, and really change their therapies so that they can take their medications. And so things that I will often do is I will decrease frequency of regimens. And so instead of a twice daily regimen, instead of taking it 3 times a day with all 3 meals, what if we switch them to once daily? And so I'll tell you, how to use extended release formulations, which are totally out there. They don't need food and they last 24 hours. The second thing I do is I reduce pill burden. And so if I can remove medications that they don't need, it frees up and lessens the amount of bottles that they have. And so, I find that taking less pills will help them to take more of their pills long term. I also want to incentivize their medications. So there are medications out there for diabetes that help them lose weight. And so a lot of my patients who have a lot of trouble losing weight, a lot of the diabetes medications we prescribe actually cause weight gain. And so if we tell them and we switch them to meds that help them to lose weight, perhaps they will want to take their meds more often. Some meds have requirements for food, and so if I remove that food requirement, if patients have food insecurity, they can take meds on an empty stomach. A lot of times I'll see providers require their patients to check their sugars frequently, and I find that that's a huge barrier to adherence for my patients because checking sugars in general while you're homeless is so difficult. And so using agents that don't require me to check their sugars, that's what I do very often. I will tell my patients that they don't need to check their sugars if I am using medications that don't have a risk for hypoglycemia. Considering risk for refrigeration, so a lot of my patients don't have refrigeration, and so being mindful of that when you do prescribe things that do need refrigeration. So things like insulin, they last 28 days outside of the fridge, and so to be mindful to don't prescribe 90 days supplies of your insulin because they're not going to be able to store all of that. And then, of course, pens and pen needles are always easier than vials and syringes, well, at least in most patients. Some patients do prefer the vials and syringes, but just trying to make it as easy as possible. And then, last but not least, if they need to check their sugars, then exploring the use of continuous glucose monitoring. I will be specifically talking about the Freestyle Libre today. I'm not sure if you've heard of this, but it's a wonderful way for patients to check their sugars. So let's talk medicine. I'm not going to go too in-depth. Hopefully this will be easy to understand for everyone. But I'm going to start off with metformin. Metformin is the one that everyone recommends. Everyone knows metformin. It's first line because it's so strong. It lowers A1C over 1.5 to maybe even 2% or more. It has cardiovascular benefit, and so it's been shown to prevent heart attacks and strokes. No risk of hypoglycemia, weight neutral, so it doesn't cause weight gain. So there's so many benefits to metformin, but many, many, many patients who are homeless will often tell me that they hate metformin because it causes diarrhea. In the package insert, metformin is recommended to be taken with food, and that's mainly to reduce the risk of side effects. But again, many of our homeless patients with food insecurity, they can't take it with food, and so if they take it on an empty stomach, it's going to cause them to have GI upset, diarrhea, things like that. And diarrhea can be so crippling if you don't have access to a bathroom. Another con of metformin is that the immediate release formulation is twice daily, which can be difficult for a lot of my patients. Taking meds in the morning and nighttime can seem simple, but in reality, it's very difficult. And so one of the pros of metformin is that there's an ER formulation. ER stands for extended release. When you take it, it slowly lasts in the body, and it releases over 24 hours, so they can take it in the morning with or without food. It doesn't matter. The ER formulation is much gentler on the stomach as well because it just slowly releases over 24 hours. Now, there's a con because usually insurances will only cover the 500 and 750 milligram strengths. And so if I do metformin extended release, then I find myself doing 3 tablets of the 750 milligram strength, and 3 tablets once a day. Then we talk about pill burden, and that's not really ideal either. And so I'll talk about ways that we can use metformin extended release in combination a little later. Another thing that, metformin that we always want to talk about is alcohol use. A lot of my patients are diabetic, drinking regularly. Is metformin safe in these patients? Well, in the package insert, we always worry about lactic acidosis. That's the risk. It has a black box warning. So patients with these factors, renal impairment, if they're 65 or up, if they, have heart failure or are constantly hypoxic, or if they have excessive alcohol intake, or liver impairment. These are all patients that we would just caution metformin. That being said, the package insert also says, patients, even if they're cirrhotic, have been shown to benefit from metformin. There's a survival benefit, and so it's kind of a, you got to weigh the risks and benefits. Honestly, here at our clinic, my endocrinologist says as long as the LFTs are normal, she feels fine doing it. And so for me personally, if my patients are binge drinking, then I would be a little more cautious with using metformin. You could consider dose adjusting it, but if they're like functional drinkers and they can kind of, wash out for the symptoms of lactic acidosis, then I would be okay with metformin. I actually prescribe metformin in patients who are drinking, and I would just monitor them a little more closely than I do. So in the past, the guidelines, they don't really recommend, metformin is first, and then everything is kind of up to the doctor. There's no real guidance on what the next agent is. These are the guidelines before. So for that reason, I see glipizide, sulfonylureas prescribed all the time as the second-line agent, just because that's what's familiar. If patients' A1C is up, I often prescribe, I see insulin being prescribed all the time, and I rarely see any of these newer agents being used in practice. The guidelines this year recently came out, and they finally took a stand, and they made recommendations depending on certain risk factors. And so if you take a look at this is a very beautiful algorithm. The left side, you'll see that if a patient has a history of a heart attack or stroke, if they have ASCVD, then using agents with stroke benefit, heart attack benefit, like the GLPs and the SGLT2s is recommended as first line before anything else. If heart failure, CKD predominates, then SGLT2s are recommended, though GLPs also have a CKD benefit. We'll go over all of that. And then I'd like to direct your attention to the middle right here. It says, if there's a compelling need to minimize hypoglycemia. This is almost all of our patients who are homeless and food insecure. You'll notice that sulfonylureas are last line, and so I'll talk about where I use sulfonylureas, but I really don't think sulfonylureas are a good fit for patients in general. And then on this blue box right to the right of the hypo box, you'll see that if there's a need to minimize weight gain or promote weight loss, this should apply to most diabetic patients because type 2 diabetes is so linked with obesity. We should not be using sulfonylureas or insulin or things that can cause weight gain in patients who need to lose weight as first line, just because, what if we can help them to lose weight? And so using a GLP or an SGLT2, which both help with weight loss, is currently what's recommended by the guidelines. And so we should be using less sulfonylureas and less insulin and using more GLPs and SGLT2s, which have so many benefits. And I'll go through each of these classes so that we all can be really comfortable with all there is to know. One of the more common reasons why I see that doctors, providers, we don't use these newer agents is because we don't know if they're covered or not. And so I'd like to direct you to this website, www.formularyLookup.com. It's a great website. You can check to see, what do your local insurances cover, and it'll be a pretty good guide on whether things are covered or not. But if you really want to know, what I recommend is Googling the insurance plan, because all insurance plans usually will post a formulary online, and so it's just a Google search away. Some insurances will require prior authorizations for these newer medications because they're expensive, and so I will often use Cover My Meds, but most insurances will actually have these already available on formulary. This right here is the Medi-Cal formulary, and so for patients with straight Medi-Cal, I just did a little quick search right here, and you'll see that even these crazy combination medications, it comes in combination with metformin, it's totally covered. Jardiance, Farxiga, also covered. And so this is another example. This is from a presentation I did for San Mateo Medical Center. What I did was I took their top 4 insurances that they see, and I kind of listed out every single diabetes the medication that's covered by them, and you'll see that things like SGLT2s, GLPs, they're all covered, and it's just a matter of the doctor just has to write the prescription for it. And so these are just examples of these medications being covered. This is kind of like an overview of how each of these medicines work. I'm not going to go into metformin for the sake of time. Sulfonylureas, they just help you produce insulin. SGLT2s, I'm going to talk about that in a future slide, and then I'll talk about GLPs and DPP-4s in the next slide too. Thiazolidine this is a medication called Actos. The way that Actos works is it increases your sensitivity to insulin, and it increases reuptake by fat cells and muscle cells. It increases uptake of sugar, and so it helps the sugar to leave the blood and go into the fat cells and the muscle cells. So anyway, I'll go over each of those in depth later. Let's talk SGLT2 inhibitors. SGLT2 inhibitors are really, really cool. Their mechanism of action is really clever, in my opinion. The way that they work is they go into your kidneys and they block reabsorption of sugar. And so your kidneys, they naturally will absorb sugar back into your body. And so the SGLT2s come in and they block that process. So when patients eat, instead of that sugar going into their blood, it goes out into their urine instead. And so one of the benefits of having this is that it leads to weight loss, because even though patients' diets are not changing, they're getting less sugar in their body. And so they pee out more sugar. That's how they work. These are the SGLT2s that are available. Jardiance is all over the commercials. You probably heard of it. But I love Jardiance. I think it's probably the best one out of the 4, in my opinion. SGLT2s also come in combination with metformin, extended release. And so these pills are once daily. So you can get a once daily version of max dose metformin with Jardiance or some other SGLT2. And patients, all they got to do is just take it once a day, and it'll last 24 hours, and it has 2 medications inside of it. It's a wonderful pill. It's just that it's kind of hard to swallow because it's a little larger because it has 2 meds. So that's something to keep in mind. It makes sure patients are able to have no trouble swallowing their medications. Another medication that I've started is Sigduo, just because that's covered on the formularies here. And so I use Sigduo XR. And I tend to stay away from Invokana if I can. And I'll go over why I do that in another slide. So pros of SGLT2s, they help with weight loss. They're once daily. The pills are really small. Clinical trials have shown cardiovascular, heart failure, and renal benefits. So they protect your kidneys, specifically Jardiance and Invokana do. They have a low risk for hypos, if at all, no risk on its own, and they have modest A1C reduction. So these are wonderful pills. And this is just, I'm not going to go too in depth, but this is kind of like what the clinical trials show. What does cardiovascular benefit mean? Basically means 40% reduction in a composite of death from cardiovascular causes, non-fatal heart attack, and non-fatal stroke. And so In addition, you'll see, all these are significant. But when you think SGLT2s, I want you to think heart failure benefit, because these drugs have been shown to reduce hospitalizations for heart failure. So if patients have heart failure and diabetes, this is definitely worth considering. This shows you the kidney protective benefits. And so I tell my patients, this will protect your kidney from getting worse. And so if patients are at risk, or if they even currently have CKD then, or kidney problems, then this is also recommended to protect your kidney from future damage. This is Invokana. I'm not going to go too in-depth. You can go back to these and download this on another time. But heart failure also reduces heart failure. So SGLT2s and heart failure, I want you to make that connection. Okay, so here are the side effects. Because, you will be peeing out more sugar. Sugar will be more coming out into the urine. The number one side effect that we want to monitor is increased risk for urinary tract infections. There's more sugar in the urine, so bacteria are a little more prone to grow in that area. And so, recommending hygiene for patients, especially if they're female. This risk is primarily for females. I also, I start a bunch of males on SGLT2s, and I've never had a male complain about UTIs just yet. But that is something to monitor. So hygiene is important. You'd expect increased urine output, but I would describe it like a thiazide. A hydrochlorothiazide causes just very mild diuresis. It shouldn't affect it too much. But if you're using SGLT2s in combination with other diuretics, things like Lasix, hydrochlorothiazide, then you want to. But this is so rare that it does not change my clinical practice, but I'm just going to throw this out there. In 2013 to 2018, there were 12 cases reported of Fournier's gangrene, but, millions of people get these prescriptions every year, so it's just something to monitor. If they have this history, then I would avoid it. Canagliflozin. Invokana has a black box warning for increased risk of amputations. I'm sure you've probably heard of this. And only Invokana currently has this. So it's not really, doesn't apply to any other medications right now. But in the trials, patients had an approximately twofold increased risk of amputation, which totally is freaky. And patients, if you tell them this, will often freak out and avoid this completely. If you take a look at it, the patients that did get these were patients with already high risk of amputation. And so according to the label, it just says to consider risk factors for amputation. So things like history of prior amputation, things like peripheral vascular disease, if they have clots, neuropathy, so if they have nerve pain, or if they have ulcers, then we want to maybe avoid Invokana in these patients. Are these a class-wide warning? I don't know. There's different literature, different studies have shown, yes, this is class-wide, and then other studies say, no, this is not class-wide. So it's not really clear. You're welcome to read the data. I've listed several really compelling papers if you're interested, but is it class-wide? I'm not sure, and so it might be a conservative approach to assume that it is class-wide just until we get a little more information. But is it going to increase everyone's risk for amputation? Absolutely not. And of course, we have to remember, what is the number one cause of amputation? Well, it's uncontrolled diabetes, right? And so what are the harms of not using this? Well, there are definitely some harms if we don't control a patient's sugars. And so that's also something to keep in mind as well. So that's SGLT2 inhibitors. If you have any questions, feel free to ask. I'm happy to answer your questions. But I'd like to proceed to GLP-1 agonists. GLP-1s are wonderful medications, and I'm going to link them together with DPP-4 inhibitors just because they have very similar mechanisms of action. If you take a look at this chart, I tell my patients GLPs work in two ways. The first way that a GLP works is that it will slow your gut down. And so patients on GLP-1s will feel fuller much faster. They don't eat as much because their gut is moving a little slower than it normally does. And so patients will eat less, which causes their sugars to be better, but it also helps them to lose weight. GLP-1s are the best medications out there for weight loss right now if they have diabetes, and even if they don't have diabetes. In addition, so that's the first way GLPs work. The second way that GLP works is that it helps the body to make natural insulin when you eat. And so I say, patients with diabetes, their pancreas isn't working as well. And so when you eat, your sugar is going to spike because your pancreas doesn't make enough insulin. And so GLPs will increase endogenous insulin production. What that means is it gives your pancreas a boost, and so it makes more insulin. So instead of your sugars spiking really high after meals, GLPs will help to reduce how high your sugars peak after you eat. And so it only kicks in with meals. In addition, so DPP-4s, they also increase endogenous GLP. And so it's not as potent as giving pure GLP to your body, but DPP-4s will increase natural GLP in your body. And so for that reason, their mechanism overlaps. And so it's actually recommended that you only pick one. Do not put patients on both because it's not really going to do anything. It's just going to increase their risk for pancreatitis. GLP-1s are injectables, and so that is one of the considerations to make. If patients don't want to inject, then you might want to avoid GLPs. That being said, they are once weekly, so that is fantastic. It is often much easier to do an injection once a week than to take a pill once a day even. And so many of my patients do really well on GLP-1 agonists just because it's available once weekly. They're extremely strong, much stronger than SGLT2s. And so they can provide A1C reduction of 2%. They also have cardiovascular benefit. I've listed exactly which ones do have cardiovascular benefit at the table above. And they cause weight loss, and they do have GI side effects. And so because they slow down your gut, patients on GLP-1s will often find that, it causes nausea. And so what I tell my patients is, don't eat so fast. Don't, eat smaller meals. If you eat too much, it's going to overload your throat, and your gut is working slower than normal, and it's going to cause your gut to be, it's going to increase your risk for nausea. Some patients also say it causes them diarrhea, so just be a little careful to counsel them. You can treat through it. It's going to be the worst in the first 1 to 2 weeks, but I find that most of the side effects will resolve after 2 weeks, and so push through and treat through the side effects if you feel like patients need something like this. DPP-4s, these are also really great. These are the gliptins, right? Your sitagliptin, your Januvia, your Tradjenta. These are once daily pills. They're wonderful. They have very little side effects, very tolerable. Their A1C benefit is a little weaker than everything else, but if patients, are close to goal, if they're like at 8% and they just need a little more, then you can prescribe a DPP-4. It's once daily, very minimal side effects, doesn't cause weight gain. I'm totally okay with DPP-4s as well. And then of note, just to back up, allogliptin and saxagliptin have a warning for heart failure, so that's just something to keep in mind. If they don't have heart failure, I'm totally okay with prescribing these, but if they do have a history of heart failure, then you want to go to the other ones, the Januvia, the Tradjenta. Okay, and this is, again, I'm not going to go over this, but GLPs have CKD benefit and cardiovascular benefit. You can read this on your own time. I'd like to show you what the GLPs look like because doctors will prescribe things and not really know what it looks like. And so this is what Trulicity looks like. I prescribe this very frequently in my clinics because it's so easy. A box will come with 4 pens that look like this. There's 3 steps. You're going to remove this little gray cap right over here. You're going to remove that. And after you remove it, then you're going to turn the top of this right over here. You're going to turn that to green, and then you're ready to inject. And you just press a button, and it will inject for the patient. And so the patient never sees any needles at all. They just put it on their stomach and press that green button, and it will inject. This is Bydureon. Bydureon is such a mess. If you see right here, the counseling point for the Bydureon pen is you got to hit it on your palm 10 times, rotate it, hit it another 10 times, rotate it, hit another 10. It's horrible. You got to hit it 80 times to mix the medicine, and so I often will avoid Bydureon. because they got so many complaints, I'm guessing, Bydureon then came out with the Bydureon B-Sice, which is a little easier. It's not really covered by my insurances, so I don't use it, but these are the instructions. You can refer to that. If you do Ozempic, which is my second most popular GLP, Ozempic looks like an insulin pen, and it actually comes with pen needles, so you don't need to, you don't need to prescribe pen needles with Ozempic. Victoza, on the other hand, Victoza is once daily. And so I don't prescribe Victoza very often, but Victoza does need pen needles. And so you'll have to keep that in mind as well. If you prescribe Victoza on its own, patient's going to have no way to inject it. But since it's once daily anyway, I will definitely prefer the once weekly often over the once daily if I can get it. GLPs are injectables, right? And so we have to talk about refrigeration. They are good at room temperature. For Ozempic, it's 56 days, so that's 2 months. It's freaking fantastic. Trulicity, however, on the other hand, is only 2 weeks, and so that's something to keep in mind is if my patients don't have refrigeration, am I okay with Trulicity? And so my mindset is if Trulicity is really the only thing that they can adhere to, then 2 or 3 weeks of Trulicity is better than nothing at all to me. And so I will often prescribe Trulicity even if they don't have a refrigerator, just because after 14 days, I'm not sure if the efficacy goes to 0% right then and there, right? I'm assuming that it's a gradient, and so maybe like an 80%, or I don't know how good it is after 14 days, but it might still be better than nothing. And so I won't avoid it. This is not a contraindication to me, but that's just something to keep in mind. And it might push you to do Ozempic instead just because it lasts a little longer outside the fridge. Again, cons of GLPs is because they slow down. You can cause diarrhea or nausea and caution in pancreatitis. And so on the label, it does say to caution. However, the clinical trials haven't really shown whether or not it increases your risk for pancreatitis, and so it's just something to monitor. If they have a history of it, it's not a contraindication for me. I'll just monitor it. I think the package says that it does increase lipase by 20%. I don't know if it's like clinically significant or not, but just to watch out for that if they have a history of pancreatitis. GLPs have a black box warning for thyroid C-cell tumors, and so the moment that I say this, then a lot of patients will freak out, but I think it's really important that providers really look into the warning, and so this was only seen in male and female rats. It wasn't seen in humans, and it's only this specific kind of thyroid cancer. The only thing that, clinically we have to think about is if a patient has a history of thyroid C-cell tumors, this exact cancer, then I will avoid GLPs, but many of them don't. I rarely see patients with this specific kind of cancer, and so I don't really, I don't let this kind of prevent me from prescribing it because it's only been seen in rats and it hasn't been seen in the clinical trials. That being said, because it's on the label, I am mentioning this and in the presentation. So sulfonylureas and Actos, thiazolidine. So sulfonylureas, everyone prescribes sulfonylureas just because they're cheap, they're familiar, they're strong, but they require food because they cause hypos. And so for patients in whom I do want something, I will prescribe glipizide extended release. Glipizide extended release slowly releases over 12 to 24 hours. And so I view it kind of like insulin, basal insulin in a pill form. And so when patients take it, insulin will slowly release. And so if they have food insecurity, I don't mind the extended release formulations. The immediate release, if they can do it, I'm okay with it, but having to take it with food, I find many patients don't adhere to glipizide very well, or sulfonylureas in general. Actos, we think, it can cause edema, weight gain, it has a black box warning for CHF, so it's not ideal. But that being said, it's great in people with kidney problems. It has a very low risk of hypoglycemia, so I actually don't mind Actos because it's also pretty strong too. It's just not what I do first. And so if you're looking for, once daily regimens, I've included a list of everything that's once daily. So if patients are struggling with this twice daily, 3 times a day, please consider using any of these right here. Again, metformin extended release, SGLT2 inhibitors, GLPs are once weekly, DPP4s. None of these require food except for, so none of these require food. So this is great. Just remember to only pick one. If you want a GLP or a DPP4, please pick one. I will frequently use combo medications as well. These are on formulary. They're totally on formulary. You can use these. And so I will often utilize Synjardy XR. That's kind of my go-to. Patients really, really, really adhere to these well if they can swallow it. If after a GLP and an SGLT2 I do need stuff and they can't do glipizide immediate release with food, then I will prescribe glipizide extended release as long as I know that they're eating at least once a day. If they eat once a day, I'm comfortable prescribing glipizide XL. I'm also okay with Actos if you need to. Actos is okay if they don't have a history of heart failure. And so this is kind of a table with everything that I've gone over today. You can reference to this anytime you'd like, but it's the benefits and the risks, everything there is to know, weight loss, things like that. Again, only pick one for the GLP and the DPP4s. But let's say a patient comes to clinic, his A1C is 13%. The natural, thing to want to do is to put this patient on insulin, right? But let's say you prescribe a combination SGLT2 metformin combination pill. Synjardy XR, you get 2% A1C reduction from the metformin, 1% reduction from the SGLT2. Let's put them on a once weekly injection, right? So that's another 2% from the GLP, and then let's add a glipizide extended release. Why not? That's another 1%. You can get 6 to 7% reduction just with 2 pills and a once weekly injection. And so I often find that most of my patients can get controlled without even needing insulin. If you just put them in a position to succeed and use medications that they can adhere to, it can be so powerful. I'm running out of time, so I'm just going to blast through the injectable therapies. This right here, it's really overwhelming, but I really just want to show you the new ADA guidelines. They recommend to consider GLPs in most prior to insulin. And so if you're the type of provider to always, go towards insulin, it's so strong, absolutely, but can patients adhere to it? And I don't know. So definitely assess adherence and consider GLP-1s in most before even starting insulin to begin with. If patients need insulin, that is a reality. Some patients, they can't just do orals and a GLP. I would consider avoiding prandial insulin just because mealtime insulin is so hard to do it 3 times a day, even for the average person. Many times you have to check your sugars before. It's impossible. And so I avoid prandial insulin in almost all of my patients if I can get away with it. If it's absolutely necessary and I need to do mealtime insulin, then I will prescribe it once daily with their biggest meal. And so that's kind of the compromise that I go with. If you need to do any insulin, definitely basal, and then do the postprandial coverage with the orals. GLP-1s, SGLT2s, they all provide postprandial coverage, right? So those are options for you as well. Now, if patients are having really difficult times checking their sugars, I often don't even require them to check their sugars, but if you want them to check their sugars, then avoid prescribing meds that need it, so meds that cause hypoglycemia. Consider, all of these glipizide extended release. Don't require them to take it with me. Don't require them to check their sugars. And then if they really, really, really do, then consider just doing it once a day, maybe like 2 times a week even. Just do baby steps, depending on where they're at. Again, this is something new, that this is continuous glucose monitoring. I find that the Freestyle Libre is the easiest thing to use on the market. It might not be the most accurate, but this is the easiest thing to use. Each sensor lasts 14 days, and patients will just implant this sensor into their arm. It's really easy. Anyone can do it. It lasts 14 days, and each sensor will hold 8 hours of data. So when you check your sugars, all patients do is they put this meter next to the sensor, and it will wirelessly transmit their sugars. But not only their sugar in that moment, it will transmit the sugars for the last 8 hours, and it will also transmit the trend of the sugar. Is the sugar going up, or is it going down? This is the future of sugar monitoring. I think Medi-Cal is currently trying to get it on their formularies, I believe. So maybe in the next year or so, this should be on formulary for everywhere. But as of right now, it's only available by Medicare. Medicare requires that patients need to be on 3 injections a day. They need to be checking 4 times a day. There's a lot of requirements that unfortunately that they need to meet. But if they have type 1 diabetes, or they have prandial insulin and they need to check their sugars, then this is absolutely a great option. And Medicare Part B, as in boy, will cover this. And so all you do is you send this prescription to a DME store, and they will ship it to your patient. These are also available over the counter, at like Walmart. Of course, you need a prescription. It's not over the counter, sorry. You can send this to like a Walmart or like a retail pharmacy and give them a coupon for it. GoodRx often will have coupons for the Libre, and it will average, the meter will cost about $60, $70, and a month's worth of sensors will also cost $60. Obviously, this is not for homeless patients, but if you have patients who do have the money, then this is an option for them as well. So at this time, I'd like to open the floor for, turn this to Darlene to kind of moderate this section, and I'll be available to answer any questions that you might have.
Great. Thank you so much, Larry. And of course, I'd like to just add that the information that Larry gave you, it's a lot. Someone asked about the recording and the slides. Yes, they will be available and on our website, and I'm just sending that information to you. If you look in the chat box, everything will be available on our website, as well as the information that he gave you regarding the medication management is in the adapted clinical guidelines. Larry wrote that section for us, and so it's very, very good and thorough. So again, we'll put the link to the guidelines in the chat box, and you'll be able to link to those and look those over. If you have any questions once you get the guidelines and you look at the information, then please let us know. So Larry, we have one question. They're asking, is heavy alcohol use a relative contradiction to, wait a minute, let me see. To avoid, okay, is heavy alcohol use a relative contraindication to SGLT2 use to avoid dehydration?
Yeah, that's a great question. I think it's just something to monitor. I guess, all meds, they have risks and benefits. It just would depend on basically if the benefits will outweigh the risk or not. If they are heavy drinkers, then you're right. Dehydration is something to worry about. And if we can get away with like other agents, if other agents might be a better fit for the patient, then obviously I would probably lean towards other stuff. But that being said, if patients are drinking a lot, they can't do injections, they need an SGLT2, I would not hesitate to use SGLT2s in my patients who drink alcohol regularly, and I would just counsel them, just to stay hydrated. And obviously, patient buy-in is always so important, and so I ask the patient, you know what I mean? And if the patient is willing to go through with it, then we just monitor that and check for dehydration if it occurs. But I wouldn't say it's strongly contraindicated, but maybe more outweigh the risks and benefits. Sorry if that doesn't really answer it completely, but that's what I'm thinking.
Okay, thank you, Larry. One more question we have now. Wondering about the use of GLP-1 agonist in a patient who has had bariatric surgery. they've had the sleeve, gastrectomy, or the RAL-NY in particular?
Yeah, actually, I'm not too familiar with bariatric surgery agents, but to my understanding, there are GLP-1 agonist agents out there for bariatric surgery, and so for me personally, I find that it's not a contraindication. I would actually be okay with a GLP-1 in a patient with a history of gastric bypass, just because we can anticipate the GLP-1 to slow down the gut, which is a good thing for patients who don't have much gut in their body, because the slower the absorption, the slower the motility, the more absorption we get, the less diarrhea that can happen. And so I would be okay with a GLP-1 agonist in a bariatric surgery patient, assuming there's no other like drug interactions with their other therapies.
Great. Okay, thank you. Are there any other questions for Larry at this time? We have a few more minutes before the webinar ends. I also put the link to the guidelines in the chat box. You're more than welcome to assess those or go to that website and download the guidelines. Is there any other, let me see, I'm looking for questions. I don't see any. Larry, do you have any final remarks that you would like to share?
Yeah, on this slide, there's so much that I didn't cover, but I just want to let everyone know that if you are interested, there's patient cases. These are real stories of patients that I've seen with really high A1Cs on insulin. What does it take to get them off? This is kind of, each of these is a really it paints a good picture of maybe patients you'll see in the field. Feel free to read through these cases and what I did. There's also some supplementary material if you're interested. I didn't really address insulin. There's so much to address about insulin as well, but feel free to read these. And if there are any other questions, you can email Darlene, email me directly, and we'll be able to take care of you. So thank you so much for everyone's attention.
Great. Yeah, thank you so much. And I don't see any more questions, so I believe that we can oh, I'm sorry. There is one more question that just came in. The question is about insurance. How is the insurance coverage for Freestyle?
For the I'm going to guess this is the Freestyle Libre. Currently, right now, at least where we are in California, Medi-Cal does not cover the Libre. And so the only way I get it is if the patient has Medicare. But that being said, even Medicare has a bunch of different requirements that the patient needs to meet before it'll even be covered. Let me go to it right here. So these are the requirements for, I'm so sorry. These are the requirements for Medicare, which is very difficult to meet. Patients need to be testing 4 times a day at least to get this covered. And so for the patients that I find have difficulty testing, I tell them, hey, just do 4 times for me at least a day, at least a week. Just do it temporarily, just for a week, so that I can submit documentation to the DME company that, hey, you are testing 4 times a week. You meet this criteria. And then they will often cover it. They also need to be on 3 injections or more a day. So really, honestly, coverage right now for the Libre is not ideal. I don't know what it's like in other states. But Medicare, this applies to everyone. I don't know if the Medicaid programs are covering it right now, but they're in the process of covering it, I believe. And so be on the lookout for those things.
This person is in New York, and they said in New York it costs $80 for 2 weeks for maintenance. So it's $80 for 2 weeks.
Okay, yeah, that's about similar to what we're paying. My patients, I will give them a coupon, a GoodRx coupon. I don't know if you guys use that in other states or not, but goodrx.com, GOODRX, and you can type up the Freestyle Libre. I often will send it to Walmart since I find that Walmart is the cheapest. not affiliated with them at all, by the way. But and the cost will be around $66 for sensors, for 2 sensors. So actually, I guess $80 every 2 weeks that's probably double the cost. So I would actually recommend GoodRx. Use GoodRx. I don't know if it works in New York or not, but GoodRx will definitely be cheaper. The price on the website is completely different from the price at the pharmacy. So don't be afraid to tell the patient that it will be cheaper at the pharmacy. I don't know why the Walmart price on GoodRx is not the same, but my patients who need this pay $66 for a whole month of sensors with this coupon. And the meter itself costs like $70 with the coupon. So
Great. Well, thank you so much, Larry, for that information, and thank you all for your questions. I think I got all of them that were here. If you do, yes, it is goodrx.com. Is it com?
yeah,
Goodrx.com. Yes,
and
that's
if
it.
you enter in like Freestyle Libre, it'll tell you the cost is like $120 or something like that at Walmart. But when you do take this coupon to Walmart tells me it's only $66. So that's kind of like a little. I don't know if it's going to apply in New York or something. I don't know, but that's what I've been doing right now.
Okay, great. Thank you so much. So that concludes our webinar. Please fill out the evaluations that will be sent or will pop up. That's the only way that we can improve on our offerings. And again, if you have any questions, more questions as you look over the adapted guidelines, or if you look through the slides and hear the recording once you access it from our website and you need to get in contact with us, please feel free to reach out to me at djenkins, Jenkins, at nhchc.org. And I can always also send any information or questions to Larry for that. So thank you all, and have a good remainder of your afternoon. This concludes our webinar. Thank you.